Good evening. So, IDFL West Bengal Academy invites you to the very first session one, episode one of the flagship academic endeavor of IDFL West Bengal State Branch, that is Dharma Adhyayan. So, on behalf of IDFL West Bengal, Namaskar and welcome to this academic endeavor of us. IDFL West Bengal happens to be one of the oldest and largest branch of IADFL. And since 1962, even before this present form of association started, our the torchlight bearers of West Bengal dermatologists, the great names were there. They started the monthly clinical meeting. And in India, monthly clinical meeting is still happening in Chennai, Astral Madras, and also in Kolkata since early 1960s. So that is also very big, other than our journal from 1955. And you will be astonished to know that in 1918, the first medical conference held also in the city, and by Vidhan Chandra Rai and Dr. Neil Ratan Sharkar. So these are the things that we have from our part of the globe. And another chapter we are opening today, this is also a flagship project from us. And I'm sure under the leadership of Dr. Shandipan Dhar and also our academic chair, Dr. Sudhir Das, every month we will organize Dharma Adhyayan. This is the session one, just like the web series, like a episode by episode will continue. This is today we will discuss about leprosy, and next, Shudip, I know he is planning about STI. So all praises to him, and thank you very much, Chandipanda and Shudip, for supporting to this, and the great faculties and Dr. Shandipan Dhar will welcome this. My job is over. Welcome to the first episode of Dharma Adhyay. Shandipanda, please.
Thank you very much, Kaushik. Good evening, esteemed panelist, speaker, and colleagues who have joined. I can see a good number have joined, for a discussion of on leprosy, which is very encouraging for all of us. It is a privilege to have a panel of most erudite experts in the field of leprosy, pan-India. I'm very happy to invite Dr. Narsimha Rao. And we have done away with this introduction with the CV because the time is very short. I wanted to devote maximum time because this is a webinar of only 1 hour, very crisp and to the point discussion should happen. So no elaborate, presentation of CV, and neither it is required because all the faculties' names are well known along the length and breadth of this country. Who doesn't know that Dr. Narsimha Rao has been working in the field of leprosy for more than 3 decades, and he organized the International Congress of Leprosy in 2022, which was a resounding success. Welcome, Dr. Narsimha. And, Dr. Pankaj Adhikari, is quite well known from Guwahati as a professor and head of Guwahati Medical College. And he also has been working in the field of leprosy for more than 2.5 decades. And he's a great academician. Welcome, Dr. Pankaj. Dr. C.S. Sirka from, Bhubaneswar is a well-known name to people along the length and breadth of IADVL. Welcome, Dr. C.S. Sirka, for his dedicated academic work in the field of leprosy. Thank you for joining. And of course, Dr. Brijesh Nair, I don't know which field he is not into. And in any quiz, Pan India, when all the quiz participants they fail to answer from the floor, 90% of the answers are given by one person I have seen over last 7-8 years, and his name is Dr. Brijesh Nair. He himself being a great quiz master. Welcome, Dr. Brijesh. And last but not the least, and the speaker, Dr. Neelakanti Das, who does not need any introduction. is a powerhouse of knowledge and duly been credited to become the convener. Am I right? Of the IADVL Academy this year, and coordinator Dr. along with Dr. Sunil Dogra, another great academician. Thank you, Neela, for being here today to talk on leprosy. I also acknowledge Dr. Sudeep Das, our academic chairperson, with very dynamic thought, and our current president, Dr. Kaushik Lahiri, to think about this Derma Adhyayan and monthly webinar, which will be actually shared across the country for an academic exercise. And to start with leprosy is simply a superb idea. So with this, I invite Dr. Nilay Kantidas to start his deliberation. And Nilay will talk today, challenges before leprosy elimination. A very important topic.
সন্দীপনদা আগে আমার
Yes.
ডার্মা উদ্যান নিয়ে বলার কথা তারপরে
Oh, yes. So before I go to
নিলয়
Nilay,
2 মিনিট শুধু
there was a small, kind of prelude to the talk by our academic chair, Dr. Sudeep Das. Over to you, Sudeep.
Okay, very shortly, Sandipanda will speak on this. But one thing is this: this program is missing our ode to Goddess Saraswati. So, with I start with that. I start with the slok Saraswati Namo Nitya Mahakaladra Kali Namo Namo Ved Vedanta Vihango Vishalakkhina Kevata Saraswati Maharage Vidya Kamala Lochane Vidya Vishalakhi Vidya Devi Namostute. So with out to this Ma Saraswati, I will start with the thing that COVID has brought us many bad things, but many good things also. The webinar, this was actually done by the honchos and all these things. But we came into the field during the period, both in the teaching as well as in the lecture sessions when we are having this COVID. And now we are utilizing this to spread our education. Why we require this Dharma Adhyayan? This is because we were practicing, not let's leave aside, we are teachers also. So practicing in the field, we hardly find time. We hardly find time to reshape ourselves. So this will give us to brush up our knowledge, to keep us updated. Unless you be updated, you cannot be updated to your patients, to your students, to everything. So this is one of the flagship programs, as Kaushik and Sandipanda has told. We'll be going as per multiple aspects with STI, Buller's disorder, connective tissue disorders, seriously. In every month, we plan to do one this thing. And there will be academic interaction and the knowledge throughout the country, not only to West Bengal. And today, in the opening session, we are focused on leprosy. I am very happy that all the panelists have agreed on phone calls to the all panelists as speakers, and also the moderator agreed on phone call. Kaushik and Sandipanda supported me in this endeavor. And I am thankful only, not thankful, I am only that I invited Dr. Nina also, that Nina can also, but she had a family marriage today, so she could not. Today in the afternoon also she spoke to me. So next time I'll be there with you. So that is a. So with that we pass on to Niloy.
Okay, thank you, Sudeep. Before Niloy starts, it is my duty on behalf of IDWL to welcome Dr. Bhumesh Kumar, who has joined. Welcome, Bhumesh. And Bhumesh does not need any introduction. He is such a dynamic dynamite, I say, not only in pediatric dermatology, our favorite specialty, where our interest overlaps between Bhumesh and me, but also in many other fields, particularly community dermatology. And community dermatology, to a great extent, embraces leprosy. So that's why, and that's how he is today. Welcome, Bhumesh.
Thank you, sir. Thank you. Thank you.
Welcome, Umesh. Welcome.
Thank you. Thank you. Good
And,
evening.
Good evening. Good evening. And now it is time for Niloy to start his deliberation on challenges in leprosy elimination. Over to you, Niloy, now. Niloy, the platform is yours.
Thank you so much, Sandipanda. I'm really grateful to IIDWL West Bengal branch to give me this opportunity to speak on the very first episode of Dharma Adhyayan. So I'm going to speak on leprosy elimination and its challenges. We have achieved leprosy elimination by definition less than 1 per 10,000 in 2005, and we are still retaining it. And we are aiming at zero leprosy by 2030. So one must be very skeptical in asking, like, are we really facing challenges? We have achieved elimination. The fact is, I'm not a public health expert. I'm not going to bombard you with data, but I'm going to present to you my experiences and perception in leprosy. We have got Dr. Narasimha Rao and Dr. Pankaj Adhikari, and they all have their own experiences in where we can discuss in the panel discussion. But my perception about leprosy is that the challenges that we face in leprosy is because of the population, the patient population. You know, the patients are impoverished. The patients are poor. And eventually, when a patient is poor, what happens that the pharmaceuticals who bring out the drugs, they don't really put much of an effort. The commitment is really lacking on pharmaceuticals. So are we seeing much of advances in development of anti-leprosy drug? No. What we are using the existing medicines. We are using the fluoroquinolone, and we are using the MW vaccines, which is, of course, a vaccine which is developed by an Indian scientist who has donated it and without keeping the patent. So MIP vaccine. So these are the medicines which are always there. And we all know there is no formal clinical trials being conducted by the pharmaceuticals in the field of leprosy. So we don't find new drugs coming. And we all know that there is an upsurge of multibacillary leprosy. And there are cases of resistance. And we have to manage it with the existing medicine. So this is one aspect of being impoverished. So, the limelight is not on you. The next is the policymakers. Of course, it's an open platform. I should not be talking much on policymakers' commitment, but we all understand that they have their own priorities. When a patient is poor and the focus is also tilted. So the policymakers may not be that much eager for an impoverished one, but yes, recently we have got our commitments. We have got our national strategic program for elimination of leprosy, which is coming up by the leprosy division, Central Leprosy Division. So yes, there is a policymaker's commitment, which is not that, should I say, strong. And one of the most important thing is health sectors. We doctors, let us be truthful to ourselves. Leprosy session in any conference, does it attract that much of a crowd? No, because the priority has changed from leprosy to something else. A student of MD examination, they study leprosy only to pass the subject of DVL. The commitment is lacking, and this is a hard truth, and that reflects in our practice. So these are three important challenges that we have. Another important thing is ostracism. Leprosy has been known, and it has been the cause of ostracism. And especially when women and children are affected, the ostracism is huge. So that actually translates into social commitment. Society tries to isolate them. So they are having a disease for which they should be getting more of an attention, or rather they are denied. So what happens actually? The diagnosis of the disease is delayed. If the diagnosis is delayed, eventually the management suffers. So if a management is suffering, it results in deformities, it results in disabilities. And once you get a disability, the issue of rehabilitation. The issue of rehabilitation is a major issue. So all these aspects are major player in case of a leprosy. Let us show you a picture. Leprosy, as we all know of. It's not a physical meeting that I will be able to see faces, but and your expressions. But do you think the person in the picture belongs to today's era? No, of course not. He must be belonging to those Dapsone era before 1982, isn't it? Where all those deformity and you see there's a patient of a multibacillary leprosy having all features of MV leprosy, lepromatous leprosy with deformities. Now let me tell you, this person came to my OPD in July 2023. Where? In Kolkata. In an urban district of Kolkata, a patient of lepromatous leprosy with grade 2 disability, and you can see the extent of involvement who lands to us in July 2023. And here I think is the challenge. If the health sector is not able to pick up those cases in North 24 Parganas, and North 24 Parganas reports zero leprosy for last 2 years, and still this case is present and they are able to transmit the infection to the surrounding, yes, this is the challenge. And you know, this person was suffering for the last 7 years and nobody paid heed. He was begging on the streets. So this is one of the major challenge. We are very happy to show on pen and paper that we have achieved elimination. We are going for zero leprosy. So do you think this is zero leprosy? I'll show you another example. This person presents to me two months ago. He also hails from, Kolkata, urban region. You can see the extent of disability in this person. And the problem is, who is going to take care of the plantar ulcer? When I contacted the orthopedician, they are, okay, leave it. Let the person go to physical medicine. The physical medicine doctors, they are eager to, push it to some other department. We talk of reconstructive surgery. And there are very few centers which takes up reconstructive surgeries. So this is the condition of leprosy. I think the pictures I'm showing is only tip of iceberg. The volcano is ready to erupt. If you are really not eager to pay attention, it won't be a disease which is, well, we have achieved elimination, but it will be really a threat in near future. Now, what I feel, now this patient was suffering from last 4 years, but he actually ignored his symptoms. I can tell you in just the findings of the study that we have conducted on the perception of leprosy patients. Why they ignore healthcare, receiving healthcare attention? There are 3 important features that we have found. One is ignorance, another is stigma, and economic burden. Ignorance because they think that one, hypopigmented patch, they're just a patch. It's not giving them much of an itch. It's not causing them much of a, pain. So they ignore. They have to come from a long distance to a hospital. They are all daily wage laborer, they are daily wage earner. One visit to a hospital is going to cause them their salary. So they are reluctant to come. No, stigma is a major issue. It's still prevailing. When you have got deformities like this, the stigma will escalate. And they are scared. The word pushto is scary for them. Once a patient is being stamped with leprosy, everybody is going to, avoid it. Why everybody? We have conducted a I think this a study on interns, medical interns, we found astonishingly almost 30% of interns, they are also hesitant getting socially accommodative for a leprosy patient. So stigma is there. They think this is curse of elderly. They think there's a bad luck. So they try to conceal the disease and the disease expands. And what we have suffered in this COVID era, that also escalated. What happened in 2001, the data of 2001 is misleading. It showed that leprosy was declining. And then people were thinking like, well, we have gone for, masks. And so the transmission of leprosy have declined. And when we find data of 2022, it's a huge escalation from there. What happened during this leprosy era, the capacity building, the IEC, information, education, and communication exercises were coming to a standstill. Their every focus was on COVID, and those 1 year affected a lot. What we have achieved for the last 10 years, that 1 year actually wasted that. The training programs were stopped. The reconstructive surgery was stopped. Case surveillance was stopped. So this is an important thing. So if I may summarize, if we have to overcome those challenges, first important thing is the undergraduate curriculum should include leprosy in the examination. Otherwise, MBBS students are not going to learn about leprosy. If they don't learn about leprosy, when they go to the primary health center, the community health center, they are not going to diagnose leprosy, and the patient will end up with deformities. You have to make doctors realize that leprosy is there. It's not something which is gone. Diagnostic facilities, we have to rely on clinical methods. There will be instances where the patient is not showing recovery after 1 year. So what you do? You say that it's a case of relapse. But when you say a case of relapse, you have to show that the BI has increased. So if you don't have a baseline BI, how can you show that the BI has increased? So when we are aiming for a zero leprosy, it is extremely essential that you do at least for, we have a limited number of patients. Do BI for every patient before starting MRT, so that at the end of 1 year, you can have this, this data to show that, no, this is not a relapse. This is, it is under control. So this is extremely important. The National Strategic Program has intended to, involve the medical colleges, and microbiology department are to be included in that. So this is an important thing. Another thing is migration issue. There are migrant laborers. Kharif season, they go to one district. Rabi season, to go to one district to cut the the crops. And so there is a Nikusht app that's there. So when a patient is transferred from, they go from one region to another, that Nikusht app helps in keeping the record and online and providing the medicines. Availability of medicine, this is a concern. One has to procure the medicine from a medical college or a healthcare facilities of a government. So when we are working in a private setup, even if you write rifampicin and clofazimine and dapsone, no, they dry up in the chemist. So a private practitioner, even though he diagnose a patient of leprosy, he won't be able to prescribe it. This is one thing the healthcare sector has to keep in mind. Another is disability prevention and management, which I think is an important issue. And Zero Leprosy aims at disability prevention. So one has to focus in, a conglomeration of the efforts of the leprosy department of, the dermatologists and the physical medicine and plastic surgeons to help in rehabilitation. And not only just reconstructive surgery, after the surgery, there are NGOs which work for rehabilitation. Sasakawa Institute, which works in rehabilitation. So they have to decentralize. Their action is very much focused to some pockets. So they have to decentralize. One important thing about rural area is, in rural area, there are ASHA workers. The ASHA workers goes, house to house. The important difficulty is in urban areas where you don't have an ASHA. So urban area is a real difficult region to work with. So these are the challenges that I feel is existing, and you all are there to find out whether it's really there. So it's This 15 minutes of my discussion is just, should I say, making you introspect into what's happening in the field of leprosy. Thank you so much. Thank you so much for attention. Now I pass on the podium to the organizers.
Thank you very much, Niloy, for your extremely illuminating talk. It was indeed a real eye-opener that even in 2024, when we boast of reaching up to moon, and there is a competition between the countries from one country to another country, which pole of the moon, who will be reached first, and all these things. Still, a disease, most ancient disease like leprosy, still remains a social stigma. It is not only a medical problem or medical disease, it is a socio-political, ethical and geological issue and serious economic burden for a society. You have highlighted that very well. Thank you very much for a wonderful deliberation. Now, I will invite the moderator, Dr. Brijesh Nair, for panel discussion, and the panelist, Dr. Narasimha Rao, Dr. Niloy Das himself, Dr. Bhumesh Kumar, Dr. Pankaj Adhikari, Dr. C.S. Sirka. I think that completes the quorum for the panel discussion. Now this, entire platform is yours, Bhumesh. Over to your Brijesh. Over to you, Brijesh.
Thank you, sir, for the kind words, kind introduction also initially. And I am indeed privileged to be invited by Dr. Shudip Dar, Dr. Kaushik Dar, and Dr. Sandeepan Dhar to this Derma Adhyayan, which is a wonderful forum for learning and which promises to be a wonderful forum in the future also. And thanks also for giving me a very power-packed panel. And I'm sure we'll be able to convey something across to the audience, which is numbering around 160. So this is the genome of Mycobacterium lepromatosis. I just got this as a starter slide. Nothing great here, but that's kind of the way that they came to the conclusion that this is a different bacterium from Mycobacterium leprae. I am not going to indulge into much of this jiggery-pokery, that is the immunology jiggery-pokery, but leprosy is an interesting disease in the sense that it has got this spectral involvement of immunology. And this slide pretty much tells us what is going on in various spectrum of leprosy. Welcome to the esteemed panelists. I'll be remiss in my responsibilities if I do not acknowledge the contributions of Dr. Nayan Patel, intellectual contributions of these two individuals, and Dr. Tarun. So let's cut to the chase. Start with this. This is the commonest dilemma that we face in our practice. A lesion like this, a red, juicy plaque over any part of the body, it as a generic case, but yes, this is this thing. So the sensations are normal on testing. So how do you approach these cases? Anyone can take it on. Pankaj Adhikari can start.
Yeah, this lesions is very juicy, this very shiny. So this is actually in the look like the borderline leprosy. Sometimes this is quite unusual. You see the only one lesion. There might be some other lesions also. If we see the only one,
any other differentials that you would consider, because the sensations, just seeing it as a clinic case who walks into a clinic. So the way you operate, that's what the youngsters want to know.
so this is the only lesions. Any other sign?
These are the only lesions.
Okay, if this only lesions, if we have some lesions, this is a sequelae and juicy nodule. The differential diagnosis of post-callosal dermal dyskinesisis is one of the diagnoses for which we will get some lesions. This post-callosal dermal dyskinesisis is usually in the face. Is usually in the face, in the nose, or in the face.
Okay.
So, as the lesions is in the neck, so I don't think it is post-callosal dermal dyskinesisis. So
Fine.
this is as there is the lesions is very spiny. The lesions is the nodular lesions, some small lesions, the papular lesions from a type of lesions. Look like this is spiny, some hypopigmentation. Sensation maybe lost or may not be lost. It is immaterial because in the if you go in the borderline cases, the sensation may be normal. So in case of tuberculoid hole, only sensation is lost. So in that situation, if you come across these type of lesions, considering different type of differential diagnosis, so we have to go for the clinical examinations. The feeding nerve. Usually, we will not get any feeding nerve, particularly this type of lesion. So we have to go for sleep smear.
Exactly. Most of these cases have very equivocal kind of a nerve examination results. That puts us even more in a dilemma. Yes, continue.
So we'll have to go for a sleep smear examinations to see if there is any solid stain bacilli or not. And definitely we'll have to go for histopathology. This histopathology will exclude some other possibilities. Definitely these type of lesions with differential diagnosis. So histopathology is the final investigation by which we can confirm whether it is a case of instant disease or something else.
And two points which I always have a look whenever I'm confused with such a thing is, one is the mother's and the loss of eyelashes. That is one. And second is earlobe infiltration. But interestingly, in this case, there is no earlobe infiltration, as you can see.
It is normal. Yeah.
Any of the
it is normal.
Earlobe infiltration mainly towards the lepromata spectrum. So not in the tuberculosis spectrum. This plaque, any plaque which is non-scaly, which is not responding with any conventional therapy and no seasonal variations, always we have to consider towards in terms of Hansen's disease.
Yes. Okay. So this is the histopath. Let me just shorten it up for you. It is a mixed kind of an endpoint. But no well-formed granuloma. You can see a few granulomas here and there, but it's not those beautiful curvilinear serpiginous granulomas that we see in leprosy. This is a more close-up picture. Neutrophils are there. Plasma cells are there. And interestingly, a few eosinophils are also there. So now how do you interpret? And 5 past GIMSA stain or all are negative. So how do you go about these cases? This is an actual real-life dilemma which we face the most. So the questions here are, would you think of leishmania in this case? I mean, a localized cutaneous leishmaniasis? Anyone?
Yes, definitely that will be a differential diagnosis for which they have to make the smear and we'll have to see the Donovan curve.
Yeah. I'll bring Dr. Nilay Kanti Das into the picture. How can we he had presented some brilliant presentations on post-Kala-Azar dermal leishmaniasis. Suppose if we had multiple nodules, not this particular case, how will you differentiate a PKDL from, say, a lepromatous leprosy? Dr. Nilay? Is Dr. Nilay here?
Earlobe infiltration is one of the
Brijesh Niloy is not a part of this panel. He has left probably.
I told that mucosal involvement is one. Second is genital involvement. That I find scrotal involvement, other things are more common in post-Kala-Azar dermal leishmaniasis. Hypopigmented macules can be seen in both. Sucy nodules can be seen in both. These are two tips which I thought can be shared with the audience. Sarcoid granulomas are a type seen. One of the cases was someone getting biopsied for multiple nodules on the neck and then finding out leprosy-like granulomas with epithelioid, non-castrating. And then 1 year MDT given, nothing happened. The X-ray and the CT scan showed multiple node involvement. And on clinician is suspecting, that is, the pulmonologist is suspecting TB. The dermatologist is suspecting leprosy. But the diagnosis ultimately turned out to be sarcoid. So this kind of dilemmas can happen. So in this way, multi-speciality interactions is the way to go ahead. Anyone has any contributions regarding this conundrum? Dr. PNR, I think we can bring him in.
No. I don't have much to say in this, but I think once that, I think you have to really stick to the basics. If you want to rule out leprosy, I think for leprosy you should have a hypopigmentation and hypoesthesia. Hypopigmentation may not be present, but hypoesthesia should be generally be present. If it is a single lesion like that, it is unlikely to be leprosy if there is no hypoesthesia. So I think and also of course the histopathology rules out. It is not in favor of leprosy, so you can completely rule it out. But of course, then what is histology showing? Again, of course, that again becomes a different ball game altogether. Then you can look at the clinically correlate the histopathology finding with the nodules and histories and other lesions, and that of course entirely different ball game. But as of leprosy, yes, I think it's for the if the audience are postgraduates, always stick to the basics. When single lesions or few lesions, less than 5 lesions are there, lesions are generally should always have hypoesthesia. So that will be the one of the first criteria which has to be fulfilled. Yes, and if you do a biopsy, then it will do histopathology. And of course, a peripheral nerve. Lastly, peripheral nerve, it is probably palpate for the great auricular nerve there. Maybe it can be slightly thickened there because it's almost looks sitting abutting that lesion. Maybe any cutaneous nerves of the C1 branch.
That's a
C1.
very important point. Greater auricular can be looked for. Suppose you have very equivocal nerve involvement. Will a ultrasound help in contributing anything more to our diagnosis? An ultrasound of a nerve?
Yeah. If you are asking me, yes. So now ultrasound.
Anyone of the panelists, feel free to respond.
Yeah, I'll just go ahead with that. So ultrasound now kind of, I mean, it's quite widely available across many centers in India. Definitely in many of those big cities and tier 2 cities also. So now radiologists are also well equipped with the probes which are required to do the superficial ultrasonography of the peripheral nerves. Yes, it can tell us what exactly that is involved, whether it is really thickened or not. And even the standards of the sizes of various nerves for Indian patients is also more or less known to us. It ranges between 6 to 9 millimeters, for example, for ulnar nerve in Indian patients. So those are all known. So a thickening which is in doubt, which is subjective, palpation is always subjective, can always be objectively confirmed by ultrasonography. Yes.
There was a dilemma which I have seen many people in various groups talking about, that is lack of clofazimine. Rifampicin and Dapsone are pretty much available. The second line drugs are available. Suppose if you do not have any access to clofazimine, how will you modify your regime?
We can add ofloxacin in this situation.
Okay, you can add ofloxacin. Yes, fine. Yeah. So that is that I think might solve. But because I also had this, I also had faced this dilemma for around a year after coming to Calcutta. Then I managed to get my supply. Now steady supply is there for clofazimine. So ofloxacin is the option that you will recommend in place of clofazimine. Fine. What about the trophic ulcers which Dr. Nilay was showing? Can we do anything about them? Of course, reconstructive surgery in very severe cases, but what can we do at our end? The panelist who has not yet come into the picture. There's one more fourth person. Not Dr. Nilay.
Can I respond?
Yes, please.
Dr. Sirka, please.
Dr. Sirka, yes.
Yeah. So regarding that, the trophic ulcers which the patient was having on the hands, I think so the most important is like probably we may have to educate the patients. Like in our institute, what we do, we have bought some instrument like utensils, glass, and how to use, how to take the tea with the this thing close, you can give them a practical education, because instead of telling them, they won't be able to do that one. You can give them a training that can help them. In addition to that, you do have to tell them that these are all curable, so that it will help them. First thing, that one. If it is on the foot or in the malleolar area, we are using an offloading method. So that is in the lateral malleolus, the people in Orissa usually sit across leg, and we are using a bangle. Now currently we have put the soles when some people are having a ulcer on the heel, we are asking them to buy a extra sole and we are marking it and making a hole over there so that we are making an offloading over there. So these are some of the new techniques that one can do and the health education will do. And they do have to take the medications both for the any infection and as well as the leprosy also they do have to take.
What about
Brijesh, just one comment. There are many questions from our innumerable viewers from all over the country. So if you can
yeah,
pick up
yeah.
at least.
So one
Okay.
thing which I think can be contextualized here is one of the questions from Dr. Megha Dongre is how is the yield of PCR in such cases where you are actually confused? It is basically the confusion in this case because there is not much of ulceration and crusting on top. Should be between a TB NTM, that is lupus vulgaris NTM, non-tuberculous mycobacteria, that is one subset, and the second will be leprosy. So, how much is your yield of PCR? I mean, does PCR actually contribute to your management? And the second thing is bacterial culture, that is mycobacterial culture for TB and NTM. These two modalities are the ones which are there in existence. So how much do they help you in practice? Any Dr. PNR can take on this question?
Yeah, thank you, Brijesh. Okay, but I'd like to say that the PCR right now is not widely available in India. Okay.
Yes.
One of the reasons is it's not standardized. There are various types of PCRs, qPCRs, RLEP PCR, various types of qPCRs, and various types are available. For all that, they are still in the laboratory stage, and the yield is around anything between 70% positivity to 90%. Some laboratories like TLM Delhi is talking about 95% also accuracy, but still it is not tested in the field. Yes. One problem with the PCR is it says the patient is having infected, but it's not that he's having disease.
Yes.
So of course, carriers also will have the positivity. So with all PCRs, you know that. So by itself, it will not be able to add. So it's like you're doing a Montu test. So basically, more or less. So like knowing that
yes,
patient.
and I've also seen that the yield for both TB and NTM as far as PCR is concerned in such suspicious lesions is very bad. It was actually quite poor.
Yeah.
So now that brings us to one more question by Dr. Anonymous attendee, who has talked about this particular scenario only incidentally. I believe he was reading my mind, I guess. So he or she is asking this question, can we have a therapeutic trial? And can we give a therapeutic trial in this dilemma? There is this concept of therapeutic trial for TB. So can we do a therapeutic trial if you're suspecting leprosy? Better to give ATT first and see, and then starting MD. So these are the practical stuff. Dr. Bhumesh, you can take on this question. Dr. Bhumesh?
Yeah. If you've seen medicine therapeutic trials mainly, if any short fevers for malaria, typhoid, like that in MDT also like that. In TB, there is a therapeutic trial, but any hypopigmented patches, especially indeterminate leprosy, generally we will go for observation for at least for 3 to 6 months. If no improvement, then we can go for therapeutic trial. Either way, either Dr. PNR has said, this he is the right person to highlight more on that.
Okay, back to Dr. PNR. The buck stocks at Dr. PNR.
No. See, I think I think what Bhumesh said is right, but only problem is therapeutic trial is done to find the therapeutic improvement in the patient. Okay, for example, for tuberculosis, you don't nothing is working. You want to give a therapeutic trial, so the cough reduces, the fever reduces, ESR becomes normal within next 1 month or 4 weeks time. So you think that you are on right course. So okay, that is what we are expecting. By therapy, you are making that patient feels better. Unfortunately, in leprosy, see, none of the signs which are present in leprosy, for example, hypopigmentation or hypoesthesia or the patch regression, will not happen very rapidly. Even after completion of 6 months of, say, for example, PBMDT for this case, even if it is were to be a leprosy case, I mean a BT case, we are sure that it may not have such a great regression in the lesion or in the signs associated with it.
And
So
particularly, sir, particularly with the resistance.
no, even
resistance
if
is always in the back of your mind.
not resistance,
Yeah.
forget resistance.
Yeah.
The patch, suppose it's a patch, the patch will not regress in
Yes.
6 months. Here the treatment is FTD. We stop after completion of therapy, but not necessarily as the signs resolve. So therapeutic trial, you'll complete 6 months, but still at the end of 6 months, you may still be having the same
dilemma.
Yeah.
Absolutely. So I think it is, I would say it is not a good idea.
Yeah, good idea. And when you, second thing is to
can I suggest something?
Yes, Dr. Sarkar, please.
Yeah. I think so. Looking into the size of the lesion, I think so. We are likely to get that change in the loss sensation. So if we are having that temperature sensation, I think so we will be able to get it because they're looking into the size of the lesion. There is likely chance that there will be some loss of sensation. Had it been a small, just like an LL or something, we do have some degree of an confusion because they will have a very less number of loss of sensation, something around 10 to 15. Maybe we won't be able to. The patient won't be able to distinguish between. But looking into the size of the lesion, I think so it would be easy for someone to able to elicit the loss of sensation and will not have a problem. And secondly, the biopsy which you saw, suppose the look is just like a very juicy one. It is either atypical LL, if you can call it. If you look at the type of the cells, then you can make a distinction. Okay, because in there will be a lot of homey macrophages will be there. So that can also give you to some extent, may not be even if you don't have the other means of just doing, I think so, you would be able to make a distinction, what I feel.
Okay. So there is another question which has come, is very relevant from Dr. Somnath Sarkar. Is there any role of prophylactic therapy for close contact?
Pardon?
Is there any role of prophylactic therapy for close contacts of confirmed cases of leprosy?
Yeah, definitely.
Yeah.
There are some providers who love rifampicin. You can add rifampicin.
Yeah.
Yeah.
Single dose
Rifampicin is.
Yeah, single dose rifampicin.
Single dose rifampicin. Fine. Suppose if a mother is pregnant, she is having a lepromatous leprosy kind of thing. Is there any role of single dose rifampicin weight adjusted for the neonate? It's just an idea. I've not come across any this thing. This is just a random thought which I had. So I don't think there is anything in the literature regarding that. And I don't think you should recommend anything which is not.
And
there are some
rifampicin is not.
Yeah, Dr. Adhyayan first and Dr. Pina. Yeah.
Yeah, because rifampicin in neonates in the literature, we have not seen any such literature where rifampicin is given in the neonates where the mother has been suffering from leprosy. And rifampicin is not available in the solution form. It's very difficult to give rifampicin in neonates.
Yeah.
Solution syrup is there, but we cannot prescribe because
we cannot prescribe it. It's not there in the recommendations also.
It is there.
Okay, another question which comes.
Yeah, can I just say? Can I just come in?
Yes,
yeah.
Dr.
So when we are giving it for a pregnant lady, I think so we can give it not that in a hurry because the multiplication of the bacilli is also slow, and we also don't say that you don't give an anti-leprosy therapy when somebody is pregnant. So in that case, I think so it is the physician's call. He can decide what is to be done.
Okay. We'll go to the slide that's not moving forward. Yeah. So that's that. Okay. So the second scenario which I see very often, in, thankfully not in my practice because we have got supervised therapy of MDT. In other centers and in non-armed forces things, the compliance is a big issue. Even with compliance, after 1 year of MDT in multibacillary leprosy, baseline BI done, which is SA6+, the slit skin smear after a year is 5. There has been improvement in symptoms. We have waited generously for 1 year. What to do next?
Continue the treatment for another 12 months.
Okay, that is one step that we are telling. So, do you think that this 12 months MDT might not hold for every case?
If any, the bacterial index 3+, even the 12 months is not sufficient. So we need to double the duration.
Double the duration. Would you think of doing a resistance testing prior to doing this?
Yes.
And incident, yes.
If
Tell me.
percentages are available, definitely we can go for that.
Okay. So who among you have sent samples to the Stanley Brown laboratory? I'm taking the name Stanley Brown because the audience should know if they do not already know. Vishnu Singh is a person whom we all know. So besides Stanley Brown, if someone is from the south, which are the facilities which offer resistance testing? Do you have any idea which you can tell the audience? Because I was inquiring. Yeah.
The Lepra India, which has a branch in Hyderabad,
Yes.
is called as BPHRC, Blue Peter Health and Research Center, also doing it.
Yes.
But you have to contact them before you send them. You can't just send them like a laboratory. So you only take, as of now, all these centers are all taking only those samples which have come from government agencies, and they are overburdened with the work. They get a lot of samples. So right now they are not open to, I mean, one and all to send them. But still, you can always contact them before sending it, then they will accept it.
Suppose we have sent the thing and we have find it to be resistant. Now, this is some data: 10% of new cases, 20% of relapsed cases, and up to 42% in non-responsive and intractable cases. We are coming across resistance. So, how will you manage a case with proven M. leprae resistance? That is, one option we have is Dr. Bhumesh had told we know that the disease is acting. We continue therapy for 1 year without doing a resistance study. But suppose we do a resistance, it comes out to be, say, rifampicin resistance. What do we do? Dr. PNR?
Yeah, see, I think, yeah, that is a rather, see, these two things we should say. We should look at this data with a bit of pinch of, I mean, a bit of caution. So they are coming from somewhere, probably China or somewhere.
Yes.
Okay. Our data mentions around 7%, maximum 15% as a resistance. Number two, we also know that, like any microbiologist will tell you, in vitro, in vivo responses vary. And number three, these also not also so much in vitro, because basically they are computer generated models, kind of, because we are not growing the bacillus and we are testing the resistance like you do for microbiology. It is basically your like RLEP and RPOBs and these kind of FOLP genes and gene locations, and looking at the modifications. Probably they are right, but probably they are has to evaluate it. And all said and done, now I think in India, as a person being aware, I mean, bit with the program for over last 30 years, our problem is probably the patients not getting adequate treatment as of now. As long as they're treating inadequately, and the resistance is bound to grow, I feel. So as we all know, inadequate treatment is the cause for resistance for every disease. So I think as of now, we are treating leprosy inadequately, because we are looking at fixed duration therapy and not treating till bacillary negativity. And now, and also combined resistance, all the three drugs is rather rare. We have rifampicin resistance in majority cases. We have ofloxacin resistance in some cases. Clofazimine resistance is not there. But we still have minocycline. We have others, fluoroquinolones. We have alternatives available, and dapsone as a mainstay. And also we are aware that resistance pattern can vary from mild, moderate, and severe. So the grading of resistance, also, for example, we know that for sure for dapsone, mild resistance, moderate resistance, and severe resistance. So I think with all that you regard, we should not get alarmed by resistance, but we should more be concerned about, as a clinician and a person working for it, I feel more concerned about inadequate treatment we are giving for the patients, and whether whatever patient are getting even 1 year also, are they taking compliance is proper or not.
So one question which I had omitted earlier from the audience, Dr. Nidhi Sharma, National Leprosy Program should have budgetary opines. That National Leprosy Program should have budget allocation for diagnostic tests, skin biopsy, nerve function tests, and WHO should incorporate drugs for reactions, especially thalidomide, into their program so that Hansen's disease is diagnosed and managed, reactions are managed successfully. Your comments, Dr. Adhikari or Dr. PNR, anyone can take on. This, yeah, Dr. PNR, please.
Yeah, okay. No, one thing I would like to say that government is doing what government is capable of doing. So I see, yeah, that's okay. We can always write to the government of India, and everybody is free to write to them. But the point I would like to bring here is, as of now, probably leprosy is one program where we are getting drugs from abroad. Getting the drugs for leprosy getting donated by Novartis through WHO to Government of India. As of now, I think government of leprosy is the only program, only disease in India for which our drugs are being donated by someone else. Whereas for HIV, tuberculosis, it's all locally manufactured. Government of India, in India, they are manufactured. Government of India buys it and gives it.
Yes.
So I think as long as we are depending on the donation of drugs, we are in a very bad position to ask them to give more.
Investigations, nerve conduction.
No. The point is that we can't ask them to donate more, is it not? Taking a donation, how can you keep on asking them to donate more and more?
Absolutely.
So
This
unless
is
you
the
come out
problem
with
with
donation, only then our government of India will becomes what is our Atmanirbhar.
The second program,
Yeah.
another programmatic question which I thought I will separate out right now. Can half yearly, this is coming from Dr. Prashun Ghosh, can half yearly door-to-door survey, H2H, home-to-home survey, be done by ASHAs in both urban and rural areas for both leprosy and tuberculosis, along with comorbidity search as part of larger spectrum of patients are more affected with these two diseases? Not a bad idea. It's a good idea because we have TB programs running. And I'm sure it's a very good idea. Someone has any comments or inputs regarding this?
Well,
I think
it's
it's
a
a
very
good
good
idea.
idea. Actually, these ASHA workers, they visit door to door in every families. And
Yes.
the thing is, to control this leprosy, as Dr. Niloy has clearly mentioned, so there should be some program that the ASHA worker and the peripheral workers should be trained properly how to diagnose what is the hypopigmented lesions or insensitive hands and feet, and what is the leprosy patient, how to prevent deformity. These type of things, that's how we should train the ASHA worker. And these ASHA workers should visit. And whenever you find, or we find some cases of in the Hansen disease in the pediatric age group, this is very important. In the pediatric age group, if we can detect the Hansen disease, then we should understand there must be some source in the family or here and there. So whenever we get a pediatric Hansen disease, we should survey, we should go that area, and we should give pressure this ASHA worker so that we can pick up the cases and we treat all cases infected by Hansen disease. And one thing I want to add, we should not, we have to do something for this patient. In my institution, all Hansen disease, whatever the patient suffering from Hansen disease, all investigations are free. All investigations are free.
That's
Our
a very
patient will not pay anything for any investigations.
Wonderful.
Starting from examination, starting from histopathology, and everything is made by free from my institution. So every government institution can take steps and pick up the patients and make everything free for the patient.
Yes, I think the World Leprosy Day celebration that we have could be a forum whereby the Department of Dermatology actually conveys this point across to the power centers of their own institute. One suggestion from Dr. Ashwini that there is one more institute with just resistance testing. Thank you, Dr. Ashwini. Iflin Institute of Health Research and Leprosy Center, Karigiri. So we at Medical College Kottayam, Kerala sent the samples there. So that is another, this SHIEFFELIN Institute of Health Research and Leprosy Center, Karigiri. So I think that is the end of the questions. Do we have more time? So I'll just, we have time. Screen has got stuck. Just one second. Okay,
Sorry, Bridges, I'm just intervening. since the discussion is going on very smoothly, and we can still see after 1 hour,
Yes,
more than 95% of the people are still staying back.
absolutely.
That is one learning I have learned over last 3 years. That at
The
the beginning of the webinar, at the end of the webinar, how many people still remains, that is the most important factor.
yes,
So just like BIMI leprosy. So I think we can carry on for another 10 minutes
yes. The
for the benefit of so many people who have taken interest
absolutely,
to
absolutely.
still remain at this hour. 137 is not a matter of joke in these
Yes.
days. Okay,
So
please carry on.
the substantivity of the audience has been pretty. So in case of rifampicin resistance, I just thought I would flash these: minocycline, clofazimine, and ofloxacin daily for 6 months, and then clofazimine with a second line drug daily for 18 months. The second line can be either ofloxacin, minocycline, clarithromycin. What about linezolid? Have you tried linezolid as an option for very resistant cases of leprosy? Anyone can take. Because
Linezolid is also, linezolid is also one drug which can be tried. Not only linezolid, some other medicines also tried. But in if you compare with rifampicin, or if you compare with clarithromycin and ofloxacin, the efficacy of linezolid, in my opinion, in my experience, I have seen ofloxacin, clarithromycin, or minocycline with, as you have mentioned, clofazimine. These are the three drugs is quite effective. And now we have seen this moxifloxacin is another very good drug,
yes, moxifloxacin.
rather than moxifloxacin.
Correct.
And rifampicin also in the literature it has
Perfect.
been seen.
One
Rifampicin is
question which I
20.
wanted to ask here, which I wanted to ask earlier, is rifampicin available in India?
No. That is the problem. Rifampicin,
Hmm.
theoretically, I am saying it is theoretically, but
Excellent.
moxifloxacin is available. So if you can replace moxifloxacin sometimes in case of ofloxacin, so it is quite effective, rather more effective than ofloxacin.
Correct. And
Then
clarithromycin,
linezolid.
yeah, clarithromycin is a very low cost option also. Among these
Yeah,
drugs, clarithromycin and ofloxacin can be comparatively considered to be low cost options. Minocycline might be slightly more expensive, linezolid obviously, rifampicin not available. Moxifloxacin is, I think, kind of on an expensive part of the spectrum, maybe.
yeah, it's
So,
true.
so these are the mutations which Dr. PNR told about. And do we have any resistance testing beyond ofloxacin and rifampicin? Because we have resistance testing for rifampicin and ofloxacin. We need to think beyond that also. Is anyone aware? Otherwise, we just keep this list.
No, as of now, I think they are only doing for these four drugs: rifampicin, dapsone, and ofloxacin. Right now, they're doing for these three drugs. So they're not doing for other drugs. Of course, they don't do. Of course, for clofazimine, they generally don't do much. Yes.
And besides relapse and non-recalcitrance of this particular disease, even type 2 reactions have been found to be a scenario which involves resistance. Your experience. Dr. Sarkar, we can bring him.
Yeah. It's a debatable one. The people do say that even treated patients can have the reactions, because it is an antigen which is responsible for a reaction to occur. And on the top of that, since every year one log is reducing, suppose in a LL Hansen, it might create some dilemma that could be some bacilli could be, live bacilli could be playing a role in that. But it is still a debatable one. One cannot say with certainty that whether the treated ones will not develop a reaction or not. It can happen because it is antigen is responsible for that.
One question which I have in this context is, if you have a reaction, a recurrent ENL kind of a reaction, which is a very, very common predicament with all practitioners face, what are the options that you can have? What are the options for, say, a recurrent ENL? ENL seems to be the more resistant variant. Dr. Umesh can take on. What will you do in a case which has got recurrent ENL?
Umesh had to leave,
Sure.
Brijesh.
Fine. So,
He has another meeting of IADVL actually.
fine. So, Dr. Pankaj Adhyayan,
Yeah, that is a big problem actually with the question. This recurrent ENL or sometimes is not responding to steroid sometimes, or if you withdraw the steroid, if you taper the steroid, and definitely the sign and symptoms of ENL is coming up. One of the patient is admitted in my department for last 6 months. So in that situation, thalidomide is, we can try thalidomide. Thalidomide is a very good drug, and some thalidomide with this thalidomide, the success rate is almost 1995.
yeah. So, what is the dose of thalidomide that
It
you
is very
that you
good.
prefer? Hello. I think
So
sir
we
has
can
got
dose
it.
this.
Yeah. Yeah. Please, you got a little connection got a little bad. So, what is the dose of thalidomide that you prefer for type 2 ENL?
Thalidomide, I start 300 to 400 milligram initially. In some patients, we go for 400 milligram.
Any difference regarding high doses of thalidomide for
If we
type 2
start
ENL?
400 milligram,
Yeah. There have been studies which say
300 and
there have been
300 and 400 milligram.
Yeah, there have been some studies which are saying 40, actually two, one from Delhi, one from Chandigarh, says that even 50 to 100 milligram of thalidomide is enough and can give more prolonged coverage because of the low dosage. So that is a point which I wanted to make. So has someone tried 50 to 100 milligram dosage, Dr. PNR?
Brijesh, I generally give the patient start only around 100 milligram.
Okay.
And maximum I have given for a patient of ENL is around 150 milligrams. I never had to give more than that. So because of the patients are, of course, they're not so hefty as in Western countries. So our average weight is around 40 to 50 kgs. So even if 60 kgs also, generally 150 milligrams is not, I find very comfortable. Patient also comfortable. So because the patient will become somnolent, and also one more problem is constipation. Severe constipation, and because of the what called some effect on the peripheral nerves and autonomic nerves. So
Okay.
with high dosages, so it will be very comfortable with 100 milligrams, and you can easily bring it on and maintain it for a long time. At 150 milligrams has a maintenance dosage, and 100 milligrams, and 150 milligrams when ENL is more. So I generally practice it, and I find it
low dose thalidomide is also an option. Low dose long.
Yeah.
Okay. There's one question from the audience. How often does thalidomide?
Can I say just add
please.
a few things to this one? Yeah.
Please.
So when somebody has got a recurrence, I think so we do have to have a look whether the drug is completing the full 24 hours or not. Sometime like now, if you divide the dose, patient who are getting in the midnight the pain and continuing to appear till the next dose can be like no may not be having a recurrence. So maybe like no one is the splitting the dose. Another one is like no what I feel is that the most of the time the rifampicin also like no when you are giving a rifampicin, it also reduces the bioavailability. Means it will decrease the level of corticosteroid in that one. So in that day, if somebody is telling that like no I do have a recurrence on the day of a rifampicin or a next day of a rifampicin, maybe like you can increase the dose of a steroid one day before and continue it at least 2 days after of the rifampicin, and then come back to the normal one. You can have a prevention of in this one. So these are some of the issue besides what we call it an infection, a diarrhea, others, whatever we call it, this thing. So these are some modifications can be done clinically when you suspect or if you inquire, that can add to something like whatever other panelists have suggested.
Brijesh, I'm sorry to interrupt, Brijesh.
Yeah.
I request you now to wrap it up within next 1.5 minutes. Yeah? Right?
Next 1.5 minutes.
Yeah.
Okay.
Yeah, we have to finish by 10:15.
Yes.
So
one audience.
Vote of thanks will need 1.5 minutes. So
No
you have
issues.
got 1.5 minutes.
No issue.
Okay,
so I think I'll go to this my customary thing before leaving. I'll just give a few inputs. How often does thalidomide cause peripheral neuritis? Is an audience question. That is the last remaining audience question. How often do you see, say, out of say 10 patients that you initiate thalidomide on?
my experience, I can say that I have not seen much of peripheral neuropathy because two reasons. One is we use it in ENL where it's basically patient is LL or BL patient, so some peripheral neuropathy is already existing, so you can't make it out, but it won't worsen it significantly. Yes. So, and constipation is also one of the things, probably gut motility is also related now. So that also it doesn't happen with the lower doses. So that's my experience. Thank you.
The highest bactericidal activity against M. leprae. Yes, ofloxacin, moxifloxacin definitely has. Moxican CV by mankind is very cheap. No conflicts of interest here. It's just a contribution to the audience. There are certain brands which are quite cheap. So that is the point. And there is issue with availability of thalidomide. So if there is thalidomide is not available, and the patient is going steroid dependent, what will be your option? I think this will be my last question.
Thalidomide is available in the market. It's not available in the government agency. It's available in the market.
Fine. So in case, non-thalidomide, they just wanted to give certain inputs here regarding both type 1 reaction, type 2 reaction. Type 1 reaction of late, cyclosporin is being touted as a very good nerve protection factor. Minocycline is also a very good nerve protector. So these are two options which can give you, obviously, a long-term steroids with a generous 5 to 6 months time frame is what we are looking at in type 1 reaction, which everyone agrees. IV methylprednisolone has been tried in type 1 reaction, suprapharmacological doses, so minocycline, this thing. And the fourth agent which I wanted to highlight, both in type 1 reaction and type 2 reaction, which have been adequately treated. That is, we are assuming that the MTT has been good, adherence has been good, the reaction is continuing. We can think of a TNF inhibitor because TNF alpha is elevated both in type 1 and type 2 reaction. And I have found very good results with, say, etanercept is my favorite in this scenario, which is because we don't want to disturb the immunity too much. Because too much of TNF disturbance, too efficient a disturbance by, say, infliximab might heal the reaction very well, but the leprosy will progress. So with this inputs, I think all the audience questions are tackled, all the audience inputs. I'll hand over the session. Thank you once again to all the panelists. Thank you once again to the West Bengal branch. I would not call it West Bengal branch, my home branch, my adopted home branch. Yeah, and it has been very interesting learning from all the panelists. I'll hand over the session back to the organizers.
Thank you very much, Bridges.
Before you take over, Sandipanda, I think we should not forget to take a group photo.
Yes.
Dr. Sirka, you are requested to switch on the camera, and Sudeep also. And unfortunately, Dr. Gumesh is busy in a meeting.
My camera is on. I don't know why it is not showing me. Maybe I become more darker than the screen.
I was wondering that why you want to remain as a Meghnad to give answers to
my
the
camera
leprosy.
is on. But it's not showing me.
Anyway, Kaushik, I think we have to abandon that idea for the time being because the two important persons are not visible. One being present also not visible, another is actually not present.
Panelist is also not visible.
Just one input, sir. But someone has just asked, what is the dose of etanercept in a reaction state? It is 50 milligram per week. So that is the audience question. And thrombotic effects of thalidomide.
Can I ask you one thing? Have you used infliximab?
No, I have not.
I've already used it.
We do not want to completely finish off the TNF. And I always think dread of this thing that if infliximab,
I can share my experience. We thought of publishing it, but we have used in 5 to 6 patients, and it has been wonderful results.
Okay, that's good. That's very good input.
How long after the initiation of MDT did you give infliximab, sir? That is the question.
When the patient was in reaction, patient was actually having type 2 reactions, not controlled even with thalidomide. Then in 2 cases we gave that, and other was type 1 reaction also where we get this infliximab. Patient was on NDT, we still give it.
How many doses of
be even a safer option in type 1 reaction than type 2 because type 2 will have more antigenic load. So that's why I was asking.
After 4 doses, we shifted to the normal conventional ones.
How long after MDT was started did you give the infliximab in type 2 reaction, sir?
In type 2? It
Yes,
was almost after 3 months, I think.
3
I don't
months. So
know.
adequately treated cases,
Adequate.
not ab initio.
How
So
many,
we should
how many,
always keep
how
it
many
as a
doses
second
is
line.
required in infliximab? Dr. Sudeep,
Huh.
how many doses of infliximab you have given?
4 doses we gave. Then after that, nobody required it. We could shift to
Nobody
the
required it. Correct. That is the point. Because see, when we give it for around 3 months to 4 months of etanercept, it's a very safe molecule. After that, the requirement of other molecules for requiring the control, that is steroids and this thing, drastically drops down. And TNF has been incriminated both ways. And I would also think of an IL-17 inhibitor in a case of type 2 reaction, because there are plenty of neutrophils. We know that IL-17 drives neutrophils. There are publications of secukinumab also in type 2 reaction. So if someone has access and availability to that drug, the type 2 option, you can think of IL-17 inhibitors. I have not tried it. I have given only TNF inhibitors. Thank you.
Thank you, Vijay, for steering the panel discussion so well. And thanks to all the erudite panelists for their extremely important and pertinent input. Now I invite our, dynamic Honorary Secretary of IADWEL West Bengal chapter, Dr. Kingshuk Chatterjee, to give the vote of thanks. Over to you, Kingshuk.
Thank you, sir. On behalf of IDVL West Bengal, I express my heartfelt gratitude to all our esteemed local and national faculties for making this episode 1 of season 1 of Dharma Adhyayan a very successful one. At this late hours, the rate of attendance and the active participation from the attendees is quite heartening on a subject like leprosy. The discussion was indeed very insightful from all our national faculties. I'd like to especially thank Dr. Narasimha Rao sir, Dr. Pankaj Adhikari sir, Dr. Bhumesh Katakam sir for his presence and inputs, Sirka sir, and Brijesh sir for his extremely insightful moderation and very useful inputs. And definitely our very own Sudip sir and Niloy sir for this novel concept. Not to forget our most dynamic president. If I am being called a dynamic secretary, then the president should be double dynamic. Actually, 2 dynamic presidents we have. Kaushik Laidi sir and our incoming president, Dr. Sondipan Dhar. And last but not the least, I'd like to thank Palson's Dharma for their wholehearted support in making this event possible, and our office staff, and all the attendees for taking time out to attend this first episode of Dharma Adhyayan. Thank you. Have a good night.
Just one addition, Kingshuk. We are going to
sir.
have our next Dharma Adhyayan series on STI, as Kaushik has already told. And probably
Yes,
the
sir.
tentative date is March 17.
Right, sir.
We'll declare it later
Yes,
on.
right, Sudip. Thank you, Sudip.
Thank you.
Good night.
And good night, everyone.
Thank you.
Good night,
Good night,
everyone.
sir.
Thank you. Thank you very much. Thank you.
Thank you very much.